X, which is introduced into the vagina the evening before for preoperative prophylaxis. Preoperatively, vaginal disinfection is performed and a disposable catheter is inserted into the bladder. A uterine manipulator is not used. The surgical incisions are first demonstrated with a normal-sized uterus. Skin incision in the lower umbilical fossa is followed by CO2 insufflation with a Veress needle. With a normal-sized uterus, we use 3 5mm trocars, one in the umbilicus and the other 2 at the pubic hair border. Insertion of the umbilical trocar is followed by the obligatory all-round inspection with the 30-degree laparoscope, for which the patient is placed in a maximum Trendelenburg position. Lateral to the epigastric vessels, the 2 additional 5mm trocars are then positioned on the right and left at the pubic hair border under visual control. The choice of a 5mm laparoscope allows the laparoscope to be used where the additional trocars are located during the operation. For example, to inspect the umbilical region from there should adhesions be present. In order to mobilize the uterus, we perform bipolar coagulation of the round ligament of the uterus, the fallopian tube, and the ligament of the ovary with subsequent dissection. During this procedure, the uterus is pulled to the respective opposite side with grasping forceps. After the removal of the adnexa from the uterus and transection of the round ligament, a coagulation track is made on the bladder peritoneum using the bipolar grasping forceps to designate the planned direction of incision for opening the bladder peritoneum. Using scissors, the bladder peritoneum is then undermined, starting from the transected round ligament, and the bladder is pushed down caudally. The procedure is then repeated on the opposite side. This is followed by visualization and skeletonization of the uterine vessels. These are also coagulated with the bipolar forceps and transected. Once the uterine corpus has been completely mobilized and the uterine vessels removed, the bladder peritoneum is mobilized again from the anterior wall of the cervix. Displacement of the bladder, as in a total hysterectomy, is not usually necessary because the uterine corpus is now transected in the upper third of the cervix, above the uterosacral ligaments which lead the cervix. For this purpose, we use a monopolar hook. Starting from the left, the uterus is grasped by its anterior wall with forceps and pulled permanently downward toward cranial. Dissection is carried out step by step from the right, with the monopolar hook. During dissection, excessive smoke can be prevented by activating the